All righty. Good evening, everyone, for the Virtual Global Spine Conference for today. To my friends in US and Canada, and good evening to those in Europe. Good morning to those in Asia Pacific, including Australia, New Zealand, and those that could join us. We have our Virtual Global Spine admin team with us, a few of the faculty, a fair few of them, including Emma does a great job behind the scenes there at the Spine Summit in Florida. And so hopefully they're able to catch this just as they're getting dressed to go out to dinner looking sharp. Importantly, today I am joined by Derek Lee. And Dr. Derek Lee is a patient advocate, a clinician, comes from a chiropractic background and a master of interviewing. He's up there with some of the best in the world at getting people, really dissecting out what people think about important issues. We're going to talk about something that I don't think all the audience is familiar with, but I think a lot of people that are around spine and spine surgery know something about it. I'll start with some of the basics and move along to some more complicated issues as we go. So really the topic of today's talk is on vertebral body tethering, and I'll explain a bit more about what that is, but I've really made it about an intersection of the surgery itself, the science that goes around this technique, and social media. And although social media has become widespread and dominant really over the last 10 to 15 years, to me, this particular technique shows the power of social media, but also the difficulties with managing the social media environment as a clinician, where you have a procedure that is theoretically so attractive, but in many ways remains flawed. And we'll talk a little bit about that as we go. This is a modification of a talk I gave at another meeting in Australia, so I apologize to my Australian colleagues, but this one is much longer. And I will get started. Now, Derek is on with me, and we have some other guests. As a lot of the faculty, I think, are at the ANS Summit, if we can, feel free basically to interrupt and ask me things on the chat box. It's interactive as always, but I may not get to all the chat points straight away. Okay, so this is a quote from Sid Field about a paradigm, which is the paradigm is really the norm. And when you're in it, you can't always see it. I think this applies to both enthusiasts for fusion surgery and enthusiasts for non-fusion surgery. And I probably sit somewhere in between these two groups. And I like to always start things with a case. So this is a patient of mine. She's a 14-year-old female. She has adolescent idiopathic scoliosis. She is a high-level dancer. She dances 4 or 5 times a week. And this is super common because the scoliosis population tend to have, not always, but tend to have very bendy joints and bendy ligaments, and flexible, bendy kids make good dancers. And so there is a high overlap between dancing enthusiasts and scoliosis, we find. It is idiopathic, so she has a normal MRI. Even though she's 14, she's premenarchal, and she's Sanders 3. Which indicates significant growth remaining. In the Sanders classification, we use, along with the RISA classification, she's RISA 1 here, but we find the Sanders classification, which is a newer classification, is a bit more reliable and useful for prediction of growth remaining. So being Sanders 3 indicates she's got a significant growth remaining. She's just really past her peak growth velocity. And this is also indicated on this X-ray. You can see she's got open triradiate cartilage. Now, I haven't put the side benders on here. She has a 57-degree thoracic curve, 51-degree lumbar curve. There is some flexibility in the thoracic curve, bending down to about 30 degrees, and her lumbar curve bends down to 27 degrees. So she has by definition, a Linke 3C curve. This means that the thoracic curve and the lumbar curve are structural. And I'm not sure who's on here from the faculty. I was going to pick on Mike Galgano because I know he does some scoliosis, but a lot of surgeons would look at this and say this is a fusion to at least L3, from probably T4 to L3, and some would go to L4. And that's something that a lot of kids that rely on their flexibility to say dance don't really want to deal with. And there are a lot of intricacies to that, but we'll come through those in a moment. So she was actually deemed a very good candidate for tethering, and she was the very first patient to have it done in South Australia. So Dr. Randy Betts, who's in that photograph with me outside Chianti, which is a wonderful Adelaide restaurant with great wine, he came down and actually advised me on this case, gave me a hand. And this is the result we were able to achieve at 1 year post-operative. So you can see we've corrected her 56-degree thoracic curve down to 26, 57 to 26, 51 to 18 degrees. And this is a fantastic result. She's back dancing and doing well. Interestingly, she did have a pleural effusion after her chest surgery, and the surgery was staged, and we had to put a small drain back in just to relieve that. I think it's interesting here, if you look at her sagittal profile, it's definitely improved as well. If you look at the shape of her neck, she has that typical neck kyphosis that gets associated with idiopathic scoliosis. And so very happy here at 1 year with her sagittal profile. So this is where everyone gives each other high fives and we think, fantastic, this is great. So I've obviously followed up for a long time. We're now at 3.5 years after the surgery was done. This is where she sits now. So her curve is still well controlled, but they've increased. And you can see that she's broken her tether here, and probably here, and probably here. Now, we expect tethers to break with motion and time, and you could make a strong argument here that the tethering has done its job. It's controlled the large curves. It's kept them to an acceptable level. And to be honest, if she had two 40-degree curves when she presented and we braced her to this level, I'd be incredibly happy. So this is a good result overall, I believe. Patients happy, families happy. So that makes a big difference as well. But radiologically, you don't get the same results as you do if you get a fusion. But what we have to look at is the function of the patient and long-term outcomes. And I'll keep following her up, and I really hope that lumbar curve doesn't progress. When we look at growth modulation, it is widely accepted in orthopedics, and even and motion preservation is widely accepted in spine surgery. So when we look at basic orthopedic surgery, we've got 8 plates for angulation of the limbs, really commonly used to guide growth in kids. You've got fascia Duval rods, and those are rods that are placed down the intramedullary canal in kids with limb deformities. And this is an example of a patient of mine who has osteogenesis imperfecta that causes bones to bend abnormally and causes deformities. And those deformities are controlled with these telescopic growing rods that are placed within the bone across the growth plate. This young lady also had a little scoliosis I was managing. But some of the best operations we do in all of medicine, not just orthopedics and neurosurgery, are hip and knee replacements, hip and knee arthroplasty. And it's controversial, but cervical disc replacement is pretty commonly accepted now, and to a lesser extent lumbar disc replacement is accepted. And I just saw that the ProDisc L has been FDA approved for 2 levels now in the US. So we are moving more and more towards motion preservation. When you look at this young lady, I followed her for about 4 to 5 years. She was braced. She's had a modest increase in her curve. She's had more fascia Duval rods as she's gone through her teenage years, but she has a manageable 35-degree curve now, and she's at skeletal maturity. So we're just watching it, and we've been happy with that progress, and she doesn't need spine surgery at the moment. So spinal fusion for progressive scoliosis is said to be the gold standard, and there are hundreds and thousands of papers on spinal fusion for idiopathic scoliosis. Interestingly, there are no RCTs. And when you look at some really long-term studies from Iowa and other places, they're confusing, and surgical techniques, modern surgical techniques, are certainly very different from those used for the patients in the long-term studies. I think when you look at techniques like Harrington rods and other CD rods, and there was a tendency towards really flattening the thoracic spine and not restoring thoracic kyphosis, because most of these patients are hypokyphotic. They're flat through the thoracic region. So how much those long-term studies apply to modern techniques, we're unsure, but certainly during the pedicle screw era, lots of surgeons have been guilty of not recreating thoracic kyphosis, and it's something we've really only focused on, I feel, over the past 10 years. At least in sort of the Western literature. I think the French were onto it a bit earlier than we were. But fusion is generally reproducible, reliable, and for selective thoracic fusion, there are low reoperation rates. And the Harm Study Group have so much great data on this, but they had a 4.1% major complication rate at 2-year follow-up. So that essentially means redo surgery, which is a combination of infection, adding on, trimming of rods, other things. And that's pretty low. I think for this type of big procedure, although you are dealing with a population that's very fit, active, generally speaking, I think that's a very good number. But not all surgeons are HSG surgeons. Okay, I think I've worked with some of these surgeons, seen them operate. I was trained with Rosemary Angie. These are literally some of the world's best surgeons doing this work and putting their data together. You know, results like this I actually see come across my desk all the time. And this patient's got some screws that are not quite in the right spot. Some are lateral, some are medial. They've had a bit of loss of correction at the top. So not an ideal radiological result, and clinically I understand this patient went on to have a revision. When you look at longer term data as well from centres that aren't the HSG, you're probably seeing revision rates at 2 years of 10%. So we have to think about the number, not in the terms of the best of the world, because we're not all the best, but what the average surgeons are doing. And it's probably closer to between 5 and 10% at 2 years for the groups of average surgeons out there. There are obviously concerns with fusion, loss of motion, failure to restore sagittal profile, which I touched on briefly, adjacent segment disease, and subsequent premature disc degeneration. There are definitely concerns with pregnancy, and there is data that shows that L3 end fusion levels for a long fusion can give problems, and L4 almost certainly does during pregnancy in terms of back pain, and then the invasiveness of fusion versus other available techniques. And certainly there is, with any posterior technique, a lot of stripping of the posterior paraspinal muscles, and the exact effect that has running into the long term remain uncertain. This is a young lady of mine who is a extremely well-educated professional. She had a thoracic and lumbar hybrid fusion. Thoracic fusion was done with hooks, and her lumbar fusion was done at the same time with screws, pedicle screws. She's had removal of her thoracic implants for some pain and prominence, and she has had a trimming of a lumbar rod as well at some point by her pediatric surgeon, who discharged her aged about 20, as many of them do. She's been following up with me in the long term. So her thoracic spine is fused despite the lack of implants there now on the plain radiographs. This is her MRI of her 2 remaining discs. She is in her 30s. She wants to start a family. She cannot even work because she can't sit for long periods of time. So this is the sort of case that makes people extremely worried about fusion for their own children, remembering that there's a strong genetic component to adolescent idiopathic scoliosis. And this has been a really difficult management problem. I actually managed this young lady's intractable pain with peripheral neuromodulation as a way of trying to avoid the somewhat inevitable long fusion to the pelvis. And interestingly, she's gone on to have a successful pregnancy to date. And so we're just tracking and following her along. But I think eventually she's going to need a L4-5 and an L5-S1 interbody fusion anteriorly, and I'll extend it posteriorly down to the pelvis, because that's not going to work forever. So we know that growth modulation works for pediatric spine deformity. There's a braced randomized controlled trial and further kyphosis studies that demonstrate braces are effective when applied during growth. The threshold of benefit appears to be around 40 degrees. So if you can catch a curve at 40 degrees or under, we tend to be able to get bracing to reverse that curve, or at least hold it approximately 75% of the time. So this is a patient of mine again, who in 2017 presented with a 22-degree curve, had a brace applied, and her curve reduced by approximately 75% in brace. Her subsequent x-rays there, age 15 and 17, the ages are on the bottom, so she had a 15-degree curve there in 2019. And continued maintenance and improvement out until skeletal maturity, age 17. And this is a very good result. So if bracing works and we can growth modulate below 40 degrees with a brace a lot of the time, why can't we apply that to surgical techniques? Now, for kyphosis, again, I've got similar wonderful results with bracing, and these x-rays are 4 years apart. Young lady with a combination of Sherman's and a little bit of postural kyphosis. And this is her brace result 3 years after bracing. And I've seen her again, and there's another x-ray to go with to see on the final x-ray there on the right, some flattened creeps associated with a brace. We eventually got a brace off at school to maturity, and they've kind of rebounded a bit. She's had a fantastic result overall. So what is VBT or tethering for the uninitiated? It's a surgical technique that requires anterolateral access to the thoracic and lumbar spine. We put screws in on the convex side of the curve with a cord, and we tension it. And usually you tension from cranial to caudal, but that can differ technique to technique and patient to patient. It is ideally placed with growth remaining, as it is essentially an internal brace, and it's growth guided. So you are not performing a fusion in these cases, although that can be controversial. We'll come to that a bit later. But a pure VBT, as it's described and as it's been tested for the FDA in some IDEs, is essentially an internal brace for curves where we know that bracing is less likely to be effective. And theoretically uses a couple of great orthopedic principles, the Huda-Volkmann law, which is about compression and tension across growth plates, and Wolff's law, which is about remodeling under load. And both these affect asymmetric growth during the growing phase. And there's a lot of basic science data out there. In 2002, Newton reported the application of VBT in an experimental setting, a bovine model, and actually created a kyphoscoliosis, demonstrating that growth modulation was possible. And there was a case report in 2010 from Crawford and Lenke that was a proof of concept in many respects. At the time, surgeons, when this first took off, and Peter Newton has the biggest early series, but Dr. Randy Betts and Amir Sundari also have excellent series on the early results. You were modifying an implant called zimmerdynesis. And zimmerdynesis was an implant that the adult surgeons amongst us may remember was designed for flexible fixation of the lumbar spine. And the screws were quite big because they were designed for lumbar pedicles. So you were using the lumbar pedicle screws and a PET cord to try to control growth in a kid. And as a result, you had to do some modifications. It wasn't perfect in terms of implants. And this X-ray on the right, you can see the top two screws, how the tip is different from the bottom, the screw further down. It's because those screws have been cut on the back table. So surgeons were literally cutting these screws with bolt cutters to length on the back table. They end up a little sharp at the end and then placing them into pediatric spine. So fortunately, we've moved on a bit from that. And within the industry, I know of at least 4 tethers that are now available. There may well be more. There's been some big FDA IDE studies, and because Scandinavians are really good at it, there is a randomized controlled trial going on right now. We're eagerly awaiting the results of a selective thoracic fusion versus tethering study that is ongoing. And the approach, well, you can use a thoracoscopic approach, a mini open approach, or a combination of the thoracic spine. And for thoracolumbar curves, you can use a traditional open approach, a mini open approach, or minimally invasive. And this is sort of a small version of the shark bite that an Australian model has had. So Natalie Rosa, she documents her scoliosis story. She's had a fusion done. She's not my patient, and I only follow her for medical purposes. So current indications in the US for the tether, basically it's a humanitarian device, and it is indicated for cob angles of 30 to 65 degrees that can take screw fixation, and they should be patients that have failed bracing or don't tolerate it or are likely to fail due to curve magnitude, and they have to have growth remaining. And that is taken from the tether system, which is the main one at the moment from Zimmer Biomet in the US. And this is a demonstration of a patient who had progressive curves, was Sandus 2, Rissa 0, premenarchal, but with closed triradiate cartilage, who's had vertebral body tethering meeting those indications. And there are some great series as part of this, and Frosby Angie, my very tolerant fellowship supervisor and mentor, has published on 112 cases. And the revision rate here at 2 years is about 13%. So as we sort of improve implants and techniques, and I think patient selection gets improved as well, we are seeing better and better results with vertebral body tethering. So we've got a patient from my friend Aurélien Corvasseur in Grenoble in France, and he's got a case series now of approximately 50 cases. where the revision rate is 10%, and and about half of that revision rate is small procedures to improve overcorrection of the tether rather than revision to fusion. So I think, again, here we're looking at results in well-selected patients. He's really keeping quite strictly to the indications of Sanders 2 to 4. So the medical genius, Sean Wayans, actually the actor, has a great quote: anytime something does that well, you've got to follow up. And there is no doubt there are some issues with tethering. These are overcorrection, failure in curve progression, sagittal profile concerns, chest complications, patient selection, which is a really big one. So I'll just talk briefly about overcorrection. It can occur if the tether is applied too early in the growth phase, and it can cause reversal of some or most of the curve. Revision usually involves releasing the tether at 1 to 2 levels. And this young patient, you can see the shift in the trunk. She's had a good result from tethering, but it's had two things happen. One, the tether is broken at L2-3, so you can see that angle over the disc and the screws. Then she's had an overcorrection at T11-12 as well, and both those just need to be corrected with a small procedure. When you look at failure and curve progression, 13 to 20% clinically significant failure rate seems to be occurring in most studies using implants designed for VBT. Now, this is all learning curve stuff, so I think we always have to look at this data with a little bit of the perspective that it's still early in the global surgical experience of this technique. Cords probably fail at a rate of 40%, but some are not clinically significant. And if the tether has done its job and growth has been modified, the curve looks good, then a late rupture is actually good in that it can restore motion. This is my patient who was on the borderline for tethering. She was Sanders 4, RISA 1, 62-degree curve. This is her initial result. 6 months after surgery, she came back with a cord rupture, and I revised her with a double tether across the area of rupture and a focal fusion across that area. She was very keen on motion retention. I could have done a selective thoracic fusion, but now over a year out, she continues to do well with a well-controlled curve. So revision tactics for this type of surgery has to be individualized according to the patient, and you don't always need to throw a long fusion at the problem. There's another case of a young Australian patient who had her surgery done overseas before VBT was really being done in Australia, and she had quite big curves. Again, family patient for various reasons, very keen on motion preservation, had an initial acceptable, successful result. With time and experience, we might have said perhaps go to L4 instead of L3 here. Has had a double tether for the lower curve and a single tether for the upper curve, and she continued to progress. And by the time she came to me with curves that are 40 degrees in thoracic and 50 degrees in the lumbar spine, we decided on a hybrid revision. So she's had basically a revision of her cord, and you can see there in the lower picture, she's had her dionysus screws taken out. So this is old dionysus. She's had her cord revised, and you can see the breaks there marked to L3 and L2 on the tether, and that's what it looks like when it comes out. And she's had a focal fusion across the apex of her curve and retethering on the remainder. And this is a reasonable result for motion retention in a patient that would have otherwise required at least probably a T4 to L3 or L4 fusion. There are some real sagittal profile concerns with tethering, and although AIS is thought to be primary anterior spinal growth disorder, any anterior column procedure can be kyphogenic, and this is a particular concern in the lumbar spine, can be a problem with large curves. So this young lady was from Britain's Got Talent, and she had surgery done in New Jersey, and it was paid for by Simon Cowell, who you may know as a controversial judge from various talent programs. And initially she did fantastically well, but she then developed a kyphosis, and I understand went on to have a fusion. And so unfortunately her procedure for a relatively large curve was kyphogenic, and she ended up needing some more work being done. Chest complications can occur, and this is something, if you do this surgery, you never want to see. I've only seen it once, and I really hope I never see it again. This is a post-op chest tube after good procedure. I was very happy with the intraoperative result, showing some milky fluid, and this is a chyle leak. Unfortunately, this resolved with prolonged chest tube drainage and dietary modification. So I got lucky that we didn't have to go back in and re-explore this, but chyle leak is a potential complication. More relevant complications are pulmonary effusions, hemothoraxes, and they're common. 10% of patients are getting these. That is despite the fact that we're not touching the disc in the majority of these cases. And that's something that patients have to be aware of, because a lot of people come to me and say that tethering is less invasive than fusion. They've read it on the internet. And this is where social media has a big role to play in patient education, because tethering, yes, it's probably less invasive to the spinal muscles, absolutely. Anytime, though, you're looking at a 10% potential pulmonary complication rate, I think that, to say it's a less invasive is probably incorrect. And in fact, I tell all my patients the first couple of days with a chest tube after a tether is actually harder than the first few days after the fusion. What I do see is that by 6 weeks, the tethering patients are probably ahead of a fusion, but by a year, selective thoracic fusion v tether, the results are pretty similar. Patient selection is the most challenging part. We could spend a whole hour on this. But if you use a rigid criteria, only 30% of presenting cases that need surgery are really eligible for it. If you use a more flexible criteria, there's a higher risk of failure. If you are taking on cases with non-idiopathic scoliosis, there is very limited data, but there's a really high demand amongst this patient population for non-fusion, because the complication rates from fusion in this population are higher, but they're probably also higher from VBT. And selective thoracic fusion is often successful in controlling a main curve and also getting spontaneous correction of lumbar curve. This is my case, couldn't control the lumbar curve, so we've had to VBT or ASC in this case, which is a double row tether, both curves, when I probably could have gotten away with selective thoracic fusion, similar to this. And again, the harm study group have shown this really nicely. So when you do anterior vertebral body tethering, this is published in the JBJS recently, and then you look at the spontaneous lumbar curve correction, it does occur, but it corrects to about 30% at 2 years. Whereas when we do a selective thoracic fusion, it corrects at least 50%, if not more, in the vast majority of cases, probably 95% of the time. So this is a selective thoracic fusion done on a mature teenager, and you can see the ongoing spontaneous lumbar curve correction, the derotation of the pedicles, and just the way it's improved continually out to 12 months with a gentle exercise program. And I expect there may be some ongoing improvement here. So we've had to change our practice as techniques involved. And I think a big thing that I've changed as a result of some excellent work by my friends in Europe is that I have really started double row tethering for all the lumbar spines. Lumbar spine is more flexible. There's more stress on tethers. There's a high risk of breakage. And my exception to this rule would be in a very small kid where getting 2 screws in is challenging. Theoretically, though, to my mind, the lumbar spine is where this is most beneficial, because I'm not sure how much as adults we move our thoracic spine day to day, and we'll come to that again in a moment. But the lumbar spine, to me, from long-term follow-up of fusion patients, seems to be where the theory is most attractive of tethering. And this is a great early result of the year for a patient that had quite a big curve that we managed to double row tether. So when you look at Per Trebuch's paper on this, basically showing that the breakage rate and loss of correction rate from double tether is much better than single tether for the lumbar curves. And there are a few examples there, but Per's work on this with Steph DePaz has been outstanding, and Alice as well as on this paper. So one of the other concerns is the complexity of revision. So we look at this patient who's an Australian patient who had a VBT done for both her curves, as really a double major curve pattern, not completely typical for AIS, but had no abnormalities on MRI. And she's had a double tether done with an initial quite reasonable result. Anticipated growth remaining was reasonable, but she did not growth modulate. So if you look at the films on the right of screen, she's now got curves that are almost worse than what she started with. She has shoulder imbalance, and she's got a lot of actual lumbar back pain associated with this. So this is a really challenging case. We've been trying to avoid a fusion low into the lumbar spine. She hasn't got a lot of growth remaining now when she comes to me with this issue. And she's got a lot of shoulder imbalance. And I've got a theory that shoulder imbalance does drive curve progression. And so we ended up looking at a revision for her. And this is what I chose to do. So I've retethered a lumbar spine with a double row tether and taken it down to L4 to try to drive that curve around. And I've fused her from T4 to T12. We've improved her sagittal profile. Hopefully by controlling that thoracic curve with a good correction, we can keep that lumbar curve under control and retain motion. But this is an early post-op follow-up at 3 months. I cannot tell you the long-term results of this technique yet. What I want to reassure surgeons of is if you have to fuse around a tether with modern navigation, it's relatively straightforward. And you can see here we've brought the curve down from 50 degrees to less than 20 quite comfortably with modern implants, just using navigation to get around the existing implants. Well, what has really been changing practice is our conflicting thoracic motion data post-VBT. And the Earl Larson's group found that there was measurable thoracic motion on imaging post-VBT, but Dr. Pez and Sandari found little difference between selective thoracic fusion and VBT when they used motion capture technology. So this is Dr. Larson's fantastic paper from the JBJS. I encourage those interested to read it. Essentially, it showed that motion is retained, but in particular, coronal plane motion is reduced by 77% following tethering. So there's motion there. It's not perfect. There's a lot more inflection extension than side to side, though. Different way of looking at it is to actually measure trunk motion rather than just measuring radiographs. And the group from the Shriners at Philadelphia found that basically a selective thoracic fusion going down to L1 or a tether had slight differences in range of motion, but these were only modest in their own words. And I understand that that's changed practice quite substantially at their center. It's also changed the way I look at things. So I had this young lad come to me for tethering opinion. He had quite a nasty progressive 74-degree thoracic curve and a 56-degree structural lumbar curve. He's linking 3CN. He's also got a little pars defect at L5 on the MRI that the keen eye might be able to spot down there. So this is a challenging case, and many people would fuse this kid to L3 would be a risk, and I'd probably take that if I was fusing, or L4. And on top of a pars defect, I'd be quite concerned about that in the long term. So this is what we chose to do: get control of the bigger thoracic curve with a hybrid type procedure. So he's had a fusion of his thoracic spine, 74 degrees down to less than 10, and he's had a lumbar tether. Now he's got substantial growth remaining still, so we're going to see how his lumbar curve continues to correct with the passage of time. Again, data on this is not great, it's not long term, but I'm concerned enough about long-term data on finishing fusions at L4 that I'm taking this approach with my patients more and more. And look, it is often all worthwhile. I mean, you see a long sweeping curve like this, with long-term follow-up, you get a great result with the tethering. A little bit kyphotic, and we've managed to get away from increasing the kyphosis in this particular case. But tethering remains really controversial, and there is real patient demand for it. But in Australia, our regulatory bodies have been involved with kind of trying to stop the procedure proceeding under our private and Medicare health funding, which is quite challenging at the moment. Whereas in the US, the insurance companies are increasingly covering it, which is very interesting, that there's sort of this dichotomy of decision-making processes going on. And this is where social media is really intersected with a surgical technique, and that there's great demand for this procedure amongst parents, patients, and advocate groups, but we're just not seeing the same demand amongst regulators and hospitals necessarily, and there's a degree of healthy skepticism amongst clinicians. And although, I mean, I certainly do the procedures as you've seen, I think a lot of the science remains to be determined, and we're really not at long-term enough follow-up to determine what the results are going to be. And we're probably not going to know for another 15, 20 years what's happening. So there are some great resources. You can always check in on our YouTube channel, but also Derek Lee's fantastic series of interviews with people doing this type of surgery, as well as basic scientists, researchers, and other clinicians. So for those that are interested, you're welcome to visit South Australia, where I am anytime. It's a big country town. I'm going to leave this presentation and see if we can take some questions. And then I'm going to get Derek Lee to have a chat about the patient advocacy and social media side of VBT. Cool. All righty, we're back on now. I've got a few people on, so I'm back on the chat box now. Yeah, so Matthew Burchuck's asked, any change in the material of the tethers? I think they've been modifying as they go. It's PET, so yeah, fancy polyethylene. And look, I think they've made minor adjustments as they go. I'd always wondered why they don't put a little metal filament within it so we can see definitively when they're broken, and we can also measure the tension in the tethers. But you know, a broken tether, as we've talked about, is not always a disaster, and therefore it's something that not knowing may be the best because it reduces anxiety. But I now think on X-rays we can certainly measure a broken tether somewhat reliably, and you can kind of see it. So why not know about it? All righty, I'm just going to have a look and see now. Derek, are you with us? Can we get Derek on? Hey, Derek. There he is, the master interviewer himself. All right, so that was a sort of wide-ranging presentation I've given, but I think the other aspect of it, as I've been talking about, is the kind of social media and parent-patient advocacy that goes on in this space. And you, the person I believe is the best kind of equipped to talk to us about that now. I know you've got a few slides. So we've got a few comments on the chat box. Alfredo Giroy has said, can you derotate? And the answer is yes, but probably not quite as well as fusion. And so patients have to be incented for that. And if significant thoracic rotation is a major concern, sometimes patients are better off with a fusion procedure. I got another comment in the chat box from Kristen Lancy. Thanks, Kristen. She's Zali's had her daughter's had a VBT revision, and she's doing really well. And so the minor revisions of VBT, where you don't have to resite screws, although it's further surgery and risk, certainly not to the degree of risk of the initial procedure a lot of the time. And that probably goes with tether releasing. And so going back to Aurelian's recent series, where he had a tether revision rate of about 10%, half of those were redos. You know, they're pretty minor redo procedures. So yeah, we're getting a few comments through. Derek, I am going to let you get on with your talk. I know you've got a few slides you want to share. Do you have any comments on my talk from what you've seen?
No, it's a terrific summary, and I think it's a really good introduction to VBT. I just want to say that social media and VBT it's a very hot topic and trendy topic, just because parents just don't want to fuse, right? If they can avoid it at any cost. And parents are looking for any kind of solutions. Well, not just parents, but patients as well, that avoid fusion. Because we do know that, you know, as you mentioned in your talk, if you go down to L3, absolutely L4, you're looking at complications, you're looking at complications in the other end in terms of failure rates above the fusion as well, in terms of kyphosis, right? But for sure, we can start the slides if you like, if we can go through that.
Yeah, we can let Derek share his screen. Just while you're sharing, Alfredo, who's one of our new panelists on Virtual Global Spine's got a question on the chat box. Do you talk about 30% revision rates when counseling the parents? Absolutely. I tend to reflect the data from the IDE FDA trials at 15 to 20% at 2 years, and maybe a bit more in the year beyond that. And that's an important part of the decision-making process to me. And I think that's improving, but I'll wait for a few more trials to come out to show that. And there's another question on robotics, which I'll come back to. I'm going to let Derek talk. Thanks, Derek.
Right. Okay. Can you see my screen?
Yep, we've got you, Derek. That's brilliant.
All right. This is my son after VBT, and this is a talk that I had prepared regarding trying to bridge the information gap between patients and their families with healthcare practitioners as well. In terms of social media, it was all about trying to share information, and it was really initiated by frustration on my part. Frustration in terms of trying to just see if I could understand and find consensus for treatment for AIS. I think it would be kind of beneficial to go through my son's story and the steps that I took in terms of trying to find consensus. Kind of started when he was about 14 years old. If you look at the 2 slides at the side, let me just expand this a little bit. And excuse me. When we look over here on the left, he just turned 14 when he was diagnosed with a 34-degree curve. And I had totally missed it. And this is the first thing that parents will come up with, which is with experiences, is the guilt. You know, we missed it. I'm a chiropractor. I totally missed it as well. From what I know now, I would be able to look at him and assess him in about 2 seconds. But at that time, I had no clue. I'm a chiropractor, but I rarely see scoliosis. My niche is basically corporate health and wellness. Anyway, from that 34-degree curve, we had to wait about 4 months to see an ortho, and 2 months within, he was wearing a modified Boston brace, which was basically a cylinder at that time. It had no derotation component built into it. And that was the first step to my frustration. I'm going, there's got to be a better way of managing scoliosis. Now, the good thing is that he's a late bloomer, and that allowed me to research a little bit more. But where do you research? First thing I looked at was PubMed, but there's so much misinformation and contradictory information on that. I even searched Google. I finally dropped into some Facebook groups that looked at different experiences from patients, from parents, and that got me turned on to the idea of vertebral body tethering. But before I went there, we tried a second shot of bracing because, again, as any parent will tell you, you want to avoid any kind of surgery for your son or your daughter. So even though at 4 months post-diagnosis, his curve was 53 degrees and way out of effective bracing range, we tried it anyway with a second type of brace, which was a Rigo Chanel. He had a really good correction to 24 degrees from 53, which was 55%. And we basically went through a series of Schroth, scoliosis specific exercises, traction, anything I could throw at it. And we were able to reduce his curve to 42 degrees with an out of brace x-ray. But I knew that it wasn't going to hold. And I had to face the reality that perhaps surgery would be the next step. So surgery started, again, researching that after I spent so much time researching bracing and exercises and anything conservative, moved into surgical options, and again, started searching PubMed, Google, Facebook groups, and vertebral body tethering I liked because being a chiropractor, I just didn't want to see any fusion because I knew what that would possibly result in, which are long-term issues going forward, depending, again, on the levels fused. And one consult I had was looking at fusion from T4 to L4, and I was not a fan of that. So where do you get the best information? I started talking and reaching out to surgeons around the world. I spoke to 5 surgeons. 4 of them agreed that VBT would be an option for my son. The reason I spoke to them was I just needed firsthand information from experts if I could get it. And I guess the next step was surgery. In December of 2019, with Dr. Sam Danny at the Shriners in Philadelphia. Of course, I'm from Canada, Toronto, and at that time, I think there were maybe about 6 or 7 surgeons that were familiar with VBT. There's Dr. Faraz Mianji in Vancouver, Dr. Stefan Ferran in Montreal, but none of them had, but other than those two, none of them had a lot of experience with VBT in terms of the numbers. That's why I went to Philadelphia. I think Dr. Sam Danny at that time had probably over 250 of those surgeries. So you try to go with the best if you can. With surgery, he was able to bring a curve down from 53 to 25 at a year afterwards, because we were expecting some growth. He was at Sanders 3B at that time of surgery, but the curve increased slightly, maybe 27, 29 degrees, maybe 30. And I was a little bit disappointed, hoping for reduced curve correction or improved curve correction, but I didn't see it at all. But for some reason, after the first year, it dropped to 20 degrees, which totally shocked us, but who are you going to argue with? So that basically was my experience with my son of trying to navigate scoliosis. And my frustration at every turn of trying to find solid information basically resulted in me reaching out to surgeons if I could. And the information I got from those surgeons was totally invaluable. And that's why when I started thinking, maybe I should just share the information with other people. Not only were the consults very, very informative, but you got to get an idea of the personality of the surgeon, what they like, what their risk level is like. And if I could expose that or show the public what these surgeons are like, then maybe a patient or a parent could basically have a better understanding. Because as you know, many consults with surgeons are maybe about 10 minutes, you're in and out. How are you supposed to make a decision on meeting a person for that period of time? So from there, I decided to create a YouTube channel and post interviews. These are all long format interviews. The shortest is maybe about 30 minutes, the longest is an hour and a half. My first interview was with Dr. Ahmet Alanay from Turkey. I just basically asked, and he said, sure. My second interview was with Dr. Petrovic, but he wasn't too crazy about Zoom interviews. So we decided to just do a written interview, but he's come along a long way as well. So these are surgeons I'm just highlighting. Of course, Mike's on here, Dr. Amir Samdani, Peter Newton, Faraz Mianji, Baron Lohner, the list goes on and on. So we have about 55 interviews, almost 3,000 subscribers and 200,000 views. So that's the YouTube channel. I think the next logical step was basically trying to create a community where parents and patients affected by scoliosis can actually reach out and talk to scoliosis trained PTs, orthotists, and surgeons. And it just so happens that I had a bit of a relationship with these professionals. And I started asking them if they would be interested in joining my private Facebook group. So members of the public affected by scoliosis can talk to them, gain insight from them. It's not to give them advice in terms of, they should do this surgery or that surgery. It's non-promotional, so you can't self-promote. And it was just an experiment, but a natural next step. And I wanted to see if it would work. And it turns out that it's working really well. We almost have, I would say, about 1,600 members. We've only been live for about 8 months or so, I think. And these are the spine surgeon experts who are volunteering their time, including Mike, Dr. Wellborn, Dr. Alanay, sorry for the typo, Dr. Ron El Hawari, Stephanie DePaz, Bob Cho, Ryan Goodwin, Baron Longer, sorry again for the next typo, and of course, Dr. Noel Larson. If you're interested in joining this Facebook group, even if you're a surgeon, I have many surgeons in the group already, PTs and orthotists. Happy to have you on board. Now, this last slide is basically just a summary of knowing what I know now, tips in terms of how I would go through navigating scoliosis again. And I'll just kind of let you read these on your own. Take a picture if you like. Mike could send these slides out to you guys.
Oh,
Happy
these
to
are great
take any
slides.
questions if you like.
Yeah, but these are the tips you gave on your Scoliosis Research Society piece, I think. Is that right?
Um,
Or did you do, was it HSG you did an interview for recently?
yes, from yes, I did
HSG,
with
yeah.
setting scoliosis straight with their
So they're setting scoliosis straight. Yeah, absolutely. So I mean, I think that's an excellent piece, and I think these are really important questions, and actually having patients armed with some information before they come into a consult. I like that. Yeah, as a surgeon, I hate being a dictator. I really hate it, and that's my style. I know that's not everyone's style, but I think if you've got patients that have some information and knowledge before they come in, it's great. I love it, and that's where but the double-edged sword to social media is that it does get confusing for patients if it's just left sort of as unfiltered information, and that's where I think where your group is just fantastic, because it sort of filters the information in that the way out stuff is sort of pushed aside, and you get I wouldn't say a definitive agreement, but at least you get a consensus on general advice from a range of experts. And it's not just surgeons. I mean, there are fantastic spine clinicians on there from bracing and exercise, and all sorts of great individuals on there that can help advise. So I think this is a fantastic place to direct your patients if you've got patients that are wanting more information. And it can be, when we do consultations with patients, I remember a very small study that one of my friends did years ago that showed people usually remember 3 key things only from any consultation. And so even if you're writing everything down, and I don't mind if patients record consultations, there's always questions and other things that need to be answered. So I think it's just a great initiative. Derek, thank you. I am just having a look and just seeing in the chat box. So Dr. Soto was mentioning that they do robotic assisted minimally invasive thoracic fusion, and the results are the same. And look, I mean, I think when you're talking a selective thoracic fusion versus tether, that is really controversial at the moment. I think, Derek, that'd be fair to say that the Schreiner study is throwing a little bit of the cat amongst the pigeons with regards to that situation. And I mean, I still offer both. And if someone comes into me and says, they want to curl themselves up in a little ball and be a high-level diver or dancer, and they're a good candidate for VBT in the thoracic spine, then I'll talk about VBT. If someone comes in and as a young lady, they don't want to do a lot of sports, they're cosmetically aware, they really hate their shoulder, scapular, and rib prominence that goes with the condition, and they're a bit equivocal on what they want, I'd probably go for a selective thoracic fusion if appropriate, because I still feel as though I can get a better derotation and a better overall curve correction more reliably with selective thoracic fusion. And so where the controversy comes to me is cases where you've got to go below L1. For example, your son, I think he's been tethered to L2 and was offered a fusion to L4. And I continue to see adults every month in practice, multiple adults who have had fusions deep into the lumbar spine as teenagers. And I think that's where we have to get perspective on long-term outcomes. And I've got a couple new messages on the chat box. Alfredo, I'm trying to let you in. You're our new faculty. Alfredo Garroy from Argentina is our new faculty, and I'll just try to unmute him if I can. Alfredo said it would be great to have a link to like participation for selecting the best candidates of VBT. Here we go. I'll see if Alfredo can come in. Here you go. You're on.
Yeah, how are you?
Hey, Alfredo. Welcome.
Phenomenal lecture, Derek. Congratulations.
That's okay. Yeah. So a length type classification, I think, would be really helpful. And I think that's what we're working on with all these studies, and particularly the HSG and other study groups. Because I think one of the important points is correction of the lumbar spine. And so if we've got a group of patients where we think we do a thoracic VBT and the lumbar spine is not spontaneously going to correct enough, then we have to go with a double. That may change decision making. So if some parents and patients and their parents are facing the possibility of a 2 tether versus a single selective thoracic, that can change the decision making process. Derek, what are your thoughts on that?
For sure. I think a classification system would be ideal. And I know they are working on it. And there's a recent study published as well with Dr. Michelle Wellborn at Portland Shriners that looked at different Lenke type curves for the lumbar spine and the success rates. I also want to say that I still like VBT for a thoracic spine if there's sufficient flexibility and if the severity of the hypokyphosis or if there's thoracic lordosis, all those variables are kind of pushing towards more of the thoracic fusion for sure, right? But I also agree, just speaking as a non-surgeon, of course, that from the surgeons I've talked to, they do like the lumbar spine in terms of as the greatest potential for the tethering and saving levels for sure.
Yeah. Look, I mean, I think thoracic tether, in an ideal patient is just a great surgery. And but there's still so much variability to me that I see. And that's where the challenge comes. And I think the other thing is awareness. So, getting a patient in at a 45-degree progressive thoracic curve is so much better than a 64-degree curve. And the results are so much better, and so this is where awareness on scoliosis comes into it. And even if you look at bracing parameters, there was a recent study from the UK that showed that of the patients that may have been eligible for bracing, they're coming so late into presentation to the clinic that they're not getting that really highly effective treatment. And the same thing I think applies for tethering. So there's a lot of work that we need to do as a community, not just surgeons, but the community as a whole, on screening and awareness, because certainly in Australia they abandoned screening, which was very interesting. I don't know, ask in Canada, they screen, Derek?
No, they don't. And I was interviewing Dr. Pedro Bergiano in Italy, and he says all his patients come late, where the curves are already established, because he thinks it's some kind of Italian cultural issue in terms of all the patients he sees are already so mature by the time he's able to assess them. So it varies so much, it seems.
Alfredo, how they go in Argentina? Do they have a screening program?
The same as Berhana. They typically came late. I got a question for both of you. The tendency today is toward using double cord in the lumbar spine, right? Due to raw fractures or revision rates or other when you use only one cord, right? So how flexible is the lumbar spine after 2 cord? Because it's pretty close to the fusion, right?
Yeah. I think that's an excellent point. I am doing some work on that at the moment, Rita, and I'm pretty sure Per would be.
Spoiler yourself, sorry.
Yeah, no, Per may be ahead of me on the curve with looking at the retained motion after double cord. But I think there is some motion retained, but I don't think it's as much as we hope. Anecdotally, I can tell you from looking at a few x-rays and other things, it seems to be about 25% motion retention. And the question is whether that's enough long-term to salvage the disc below it. My feeling is it may well be, but I'm not sure. I suppose in a more pure tether situation, if they do break, and they tend to break at L2-3, then that restores motion. If it's done its job and you got a breakage, to me, that's actually not a bad thing. Derek, I don't know, you're actually more on top. I admit you are more on top of the research than I am.
Right.
Well, is there anything on the double cords at the moment that you've seen?
Yes, I think Dr. Trobisch in Germany published a paper on single versus double curves cords in terms of movements, and even Dr. Larson at Mayo published a paper on. I think you referenced it.
Yeah, that's a single cord for thoracic.
Yeah.
I'm not sure on double cord, and where I think we do need to look at it is, as the group from Shriners have done, is on the camera motion data, because I think just looking at radiographs can fool us a bit. I think both are important to clarify what the segmental motion is doing and also what the motion of the whole patient's doing.
And also Dr. Faraz Mianji, when I interviewed him as well on BBT, their intention at the beginning was to actually, once the child hit maturity, they were going to go in and actually cut the cords because they thought that the retained tension and the loss of motion would affect the health of the spine. So their full intention at the beginning, when they were sussing out VBT, was to go in once maturity hit and cut the cords, which is pretty interesting. So cord rupture isn't always a bad thing, and as we were relating to before, I think it's a really good thing for traditional VBT once maturity is hit and the discs and the vertebrae squared off somewhat to support to the ruptures.
Yeah, certainly not a disaster if it's applied properly.
No.
All right, Derek, I'd like to thank you so much. We're just beyond an hour, and I'm sorry my connection dropped out briefly. Yeah, you just do amazing work. I think just keep doing what you're doing. Everyone in the community is really thankful for what you do. We're trying to get you back on here sometime as things develop, particularly for a positive randomized controlled trial. If a negative one comes out, I think we've got to keep discussing these things. Alfredo, thank you for joining us. That's your first kind of semi-official faculty role. And thanks for running things in the background. And we will see everyone next week. It'll be on Twitter and LinkedIn as to what we're running. I think a whole bunch of the faculty are enjoying some drinks in Florida at the moment. So to all those that are listening in the background, think of me as I go into the OR. And thanks, Eric. Thanks, Alfredo. Thanks all. Thanks for joining us.
Thanks, guys. Take care.
Bye.
Okay, have a good day.